I'd like to welcome everyone to the Antimicrobial Stewardship Project webinar series. Welcoming everyone all around the world. So good afternoon, good evening, and good morning. This webinar is hosted by the Center for Infectious Disease Research and Policy at the University of Minnesota. I'll be your moderator today. I'm Dr. Marnie Peterson, and I'm the outreach coordinator for the project at the University of Minnesota. And I've spent the last 25 years focused on antimicrobial resistance as an educator and also as a researcher. Our topic today is diagnostics and antimicrobial stewardship. How can we elevate? So we're trying to go to the next level here with this webinar series today. We have two incredible speakers today. Professor Dilip Nathwani joining us from Scotland, and Professor Philipp Schuetz joining us from Switzerland. And I'll introduce them formally as we get into the webinar. But I have a few slides for our registration participants today to go through before we begin our webinar. So first, just to let everyone know, this is an educational activity that also provides CE to those that participate. Both CE for pharmacists from an accreditation council for pharmacy education, and 1 hour CE will be awarded for this educational content, as well as ACCME for physicians will be provided. And there'll be a code at the end and some information as to where you can go to obtain your certificate and take your post-test. Our target audience today is all of you, of course, and we're trying to provide educational needs for physicians and pharmacists, and that's why we offer this CE to all of you. Our funding, we'd like to thank bioMérieux as for providing an educational grant to us, to the Center for Infectious Disease Research and Policy, to bring you this content and these speakers to you today. Slide about disclosures, as is common with CE. It's the policy of ProCE, our CE provider, to ensure balanced, independent, objective, and scientific rigor to all the content and educational activities. And our faculty today and all of the individuals that participated in arranging and organizing the content today provided disclosures that you can see there on your screen. Myself, no relevant conflicts. Dilip Nathwani, as no relevant conflicts of interest. Philipp Schuetz has disclosed that he has received in the past consulting fees from bioMérieux, Roche, Diagnostics, Thermo Fisher, and the other individuals from CIDRAP, Christine Moore, no relevant contacts, Maya Peters, who's in the background helping to produce this webinar, also no relevant contents, and the staff at ProCE as well, no conflicts. All right, so this is the information that you need to complete the online post-test and evaluation. So this content will be hosted on ProCE. You'll see there www.proce.com, where you'll be able to go and take your post-test, print your CE statement of completion. It's important, and I would make a note of this, that the deadline is December 4th, so 30 days from now, to complete this activity. And from your live activity today, to be able to get your CE credit. An attendance code for that you will need, we will be providing on our last slide. The objectives for the presentation today, learning objectives include describing the clinical outcomes of implementing antibiotic stewardship interventions, employing strategies to more successfully implement antibiotic and diagnostic stewardship interventions in their practice settings. This is a very important topic today, and we will be getting into more details. And then also utilizing Procalcitonin as a biomarker to provide prognostic information, guide antibiotic therapy, and improve clinical outcomes. So I'd like to welcome our first presenter today, Professor Dilip Nathwani. Part 1 of our webinar, the title being Understanding Barriers and Creating Strategies for Optimization of Antibiotic and Diagnostic Stewardship. Professor Nathwani is Professor of Infection past president of the British Society of Antimicrobial Chemotherapy, and also the editor-in-chief of JACAMR, a journal focused on antimicrobial resistance and stewardship activities. And I definitely encourage all our registrants to go to their website to look at their content and also submit research in the future to that journal. So with that, Professor Nathwani, welcome to the webinar today.
Thank you so much, Mani. Ladies and gentlemen, it's my pleasure to participate in this interesting webinar on the topic that Mani very nicely has described. So what I would like to start off and talk about is, in this current day and age, we need to think about how do we optimize the impact of antimicrobial stewardship programs. Many of us try very hard to do that in our healthcare systems, particularly hospitals. But what I'm going to try to understand is, how do we improve on what we currently do? Before we do that, we need to understand what are the barriers. And these barriers will allow us to think about strategies for optimizing not only the use of antibiotics, but how the importance of getting the diagnosis right and correct at the early stage to ensure that the treatment that is delivered is appropriate and adequate. I'm just trying to move on to my next slide. Thank you. But I think we're in an unprecedented time that all of you will agree. The COVID-19 pandemic has really made us aware the importance of diagnosing COVID-19 infections, diagnosing COVID-19 infections with secondary bacterial infections. And I think it also helps us recognize that whilst we have this terrible crisis at this given time, the medium to long-term consequences of antimicrobial resistance will remain significant, if not greater, in terms of morbidity and mortality that we're seeing now. So at all times, during this pandemic, during future pandemics of viral infections, we need to ensure that antimicrobials are used appropriately and that the AMR and the AMS focus are aligned to whatever illness happens to be causing our healthcare systems the greatest amount of stress. When you begin to understand what are the factors contributing to antimicrobial resistance, all of us are familiar with antimicrobial use in humans, misuse as well as overuse, as well as the animal population. But I think increasingly, particularly in the hospital setting, but as much in the community setting, we're beginning to challenge about how do we get the diagnosis correct, and how do we ensure that getting that diagnosis correct will reduce the fear of diagnostic uncertainty, thereby leading to a more optimal targeted treatment. And at the end of my presentation, I explore the role of diagnostics, and Philipp will talk about the role of biomarkers in this decision-making process. Trying to understand what drives a clinician in any particular healthcare setting to make an antimicrobial prescription is important. There's an interesting dynamic between the patient and the clinician. There's an interesting and important dynamic about the context of where the prescribing decision is being made. At all times, there is an element of managing risk. There is a fear factor, there's an anxiety factor, and an emotional factor that will lead to the prescription of the antibiotic. And all of this is mixed with perception of the problem, or in many circumstances, the misperception of the problem, often leading to misuse or overuse of the antibiotics. And as the slide with the arrow shows you, that knowledge can be an important driver of all I've talked about, but certainly in the hospital setting, there is a frustration about the delay in diagnosis. There's actually good evidence there is a mistrust of diagnosis, and also the fear of clinical failure. And there are many, many determinants that we need to understand so that we can help optimize that antimicrobial prescription process. And this slide is a qualitative investigation and clearly shows to me what I have seen in 35 years of practice, that is often driven by anxiety. They do not want to get it wrong when they've got a patient with an unwell syndrome in front of them. And because diagnostic uncertainty, and there's an amount of time, often 24, 48 to 72 hours before you know what the bug is and what it is susceptible to, there is this fear that I must get what I use optimal to reduce harm to that patient. But the interesting concept is really now illustrated in this very excellent survey. When you look at the literature, there's actually very little qualitative research helping us understand the psyche of the clinicians, and in this case, the intensivist. And when you talked about what would intensivists really like in terms of their wish list, when these are intensivists managing patients with multi-drug resistant infections, they talked about the importance of training and education, which is what we're doing now. They talked about the importance of infection prevention, the opportunity for specialist consultation, and all the other things that we take as important. But the most important factor, what they wanted, a faster and a better microbial diagnostics to help them target their treatment in a timely fashion and in an appropriate fashion. So why is this so important, that you need to get the treatment in the early stage of the patient's admission, because it will impact on the outcomes? And this really very thoughtful paper from the Wellcome Trust, looking about how potentially better diagnostics and newer diagnostics can enhance that decision-making process, will be familiar to all of you looking at this webinar. It will allow you to target treatments better. It will allow you to use less treatments, less broader treatments, less combination therapy, often unnecessary. It will also ensure that the outcome in terms of treatment failure is less likely, because you have not only information about the likely pathogen, but also the potential susceptibility pattern to that pathogen. You have better use of culture, and all of these, if they're integrated into that important decision-making process, will enhance the ultimate outcome of the patient. And that outcome is reduction in mortality. And this very recent study looking at one of the most serious infections in terms of survival from bloodstream infections quite eloquently shows that for each day that you're not certain of the diagnosis, the likelihood of mortality will increase. In the case for MSSA as well as MRSA, and a range of resistant gram-negative infections. So there's good evidence to support why getting that treatment, appropriate treatment to the patient early in the evolution of the illness is so critical. Stewardship is really how you can optimize that process at an organization or healthcare system approach, be it in a clinic, be it in a hospital, or at the patient level. It's more about optimizing the selection, dosage, frequency, and duration of the treatment so as to optimize key clinical, microbiological, as well as harm-related outcomes, for example, toxicity for an aminoglycoside. But I introduce also within the definitions used for stewardship is to ensure that we get the diagnosis right. Make sure they take the culture, and the culture is of high quality. Make sure that appropriate microbiological tests are undertaken, and then they're communicated to the patient in a timely fashion, supported very often by the antimicrobial stewardship team. If you do all of these well, the benefits are immense. Patients are safe, patients have better outcomes. We actually will control, if not reduce, long-term costs, and we will reduce ecological harm, understanding that as being resistance or Clostridium difficile. But at all times, whenever we undertake an intervention, we have to think, is there an unintended consequence of what I'm doing? And that is an important part of a mature antimicrobial stewardship healthcare system. The decision-making pathway, as outlined in this slide, is familiar to all of you. Take a healthcare-associated pneumonia, will require admission to hospital, will often be in an inpatient facility, usually a critical care facility. You'll need to make a decision about what is the treatment, what diagnostic support you need to establish the diagnosis. If it's a COVID-related illness or a multi-drug resistant pathogen, do you involve the infection control community? And interestingly, for COVID, would you put them in a potential clinical trial? As the decision maker is usually somebody in the critical care setting, or an intensivist, or a physician, either in a surgical or a medical specialty. But the key diagnostic conundrum is it a viral or a bacterial infection or a fungal infection? What is the species? What is it susceptible to? Is it a high load disease that's more likely to require a bactericidal agent, for example? What is the likely or definite resistance profile? And is this the pathogen that is actually leading to the illness, or is it a colonizer? All of these are important to optimizing, and the stewardship decisions will actually support that. So to me, the concept of stewardship is not something alien and out with the normal decision-making process that you and I make every day in clinical practice. What is the indication? What am I treating? What is the inflammatory process? What is the microbe? What am I going to prescribe? Why am I prescribing it? Is it a severe illness? What are the comorbidities? What is the allergy? And at all times, we must instigate a process of reflection and review. When you have clinical progress ahead of you, you have microbiological data coming in front of you, as well as biomarkers and imaging and so on. The decision-making process to stop or curtail the treatment is often the hardest for many of us in everyday clinical practice. But we all know that stopping often is not harmful if it's done appropriately, and de-escalation is a well-known strategy. And all the stewardship interventions are aligned to support that. There may be persuasive interventions such as education. Guidelines are increasingly used to guide the treatment to ensure that it is appropriate to the organization's problem areas. Supporting and feedback and discussing in light of evolving results is an important stewardship strategy, as well as a whole bunch of structural things that you can put into place to ensure that antibiotics, for example, are given appropriately in a timely manner. And there is, in many organizations, more restrictive things like pre-authorization and automatic stop orders, which I'll explore very shortly. But I think these concepts are illustrated in the sense they're called front-end and back-end strategies, and will be familiar to this audience. And we use many of them in everyday clinical practice, depending on where you are. You use front-end, such as guidelines, policies, formulary instructions, pathways to protect from overuse and misuse. And we always use the back-end, which may be more resource intensive, but potentially of more long-term benefit in terms of reviewing the information, working with the multidisciplinary team and the attending clinicians to help them make the right decision to optimize the selection of the appropriate treatment. But having said all of that, if you look at the finest review of the effectiveness in the real world of antimicrobial stewardship, if you put this menu of interventions in place, you will get around a 15% increase in compliance with desired practice. Not 40 to 50%, 15%. And what will that look like? Well, it'll be about 2 days of less antibiotics, about a bit more than a day of less stay in hospital or ICU or HDU. And at all times, reducing antibiotics will not compromise patient safety. And that is, again, a very important message to the people who are hesitant when you're using less antibiotics or for shorter durations and so on. And when you look at the 3 commonest used interventions in terms of technical interventions in a systematic review, actually following guidelines well impacts on mortality, a 35% relative risk reduction. Getting a culture and then de-escalating in an HDU or an ICU setting has an incredible impact on mortality if done appropriately and safely. So this actually is very important in terms of stewardship interventions, and getting a patient reviewed armed with expertise, microbiology, and other information, actually will enhance the outcome for that patient. So we have some very powerful evidence that this stuff works. What works better? Well, if you really want to bring about sustainable improvement in prescribing, post-prescription review and feedback is perhaps the better long-term sustainable strategy. But if you have a problem with poor compliance and poor use at the front end of a prescription, then perhaps using restrictive strategies to enhance guideline compliance over a period can be helpful. And I think all of us, depending on which situation and what resources we have, will use a combination of both. And this data from China shows in 116 tertiary hospitals across China, post-prescription feedback was by far the most commonly used stewardship strategy compared to, for example, pre-authorization, in which only 50% of hospitals use. And you have to make your own decisions because you will understand the culture of your organization of how they will respond to the range of stewardship interventions. When you look at the value of stewardship programs, this systematic review showed on a range of outcomes, which I outlined in the box on the right-hand side. You improve a little bit of reduction in length of stay. As I've said, you bring about a reduction in mortality, and a whole bunch of other outcomes in terms of cost and so on are outlined in this slide. But again, if you then go on to look at healthcare interventions across a whole range of interventions in health and disciplines, not only infectious diseases, it's fascinating that printed materials, educational meetings, audit and feedback, computerized reminders, all will bring about between a 5 to 15 to 20% improvement in practice. Lo and behold, the stewardship is around 15%. So that is doing things well. That's the best we're beginning to achieve. And all of you may be surprised or perhaps even disappointed that we're not doing better. And the question I'm going to ask in the second half of this presentation is, how can we do better? Because when we do implement with education, with restrictive policies, with audit and feedback, people can circumvent them. And this is some really interesting data, which I don't have time to get through, showing that in the real world, that often will happen. The question I have to ask is, how do we improve? Can we implement better? And can we actually have better diagnostics to get us where we want to be? And this really eloquent and very thoughtful paper from 2005 makes the argument that whilst innovation and technological advances are very important in getting us to the next step of improving our practice, more effective implementation and really concentrating on improvement in implementation science to actually improve the fidelity of our interventions is equally worthy of intervention and investment, I beg your pardon. So we need to understand what works, why does it work, for what, in what setting, when does it work, and for how long. And the how long question is the sustainable bit, which many of us struggle in across the healthcare systems. And this very eloquent paper, and I apologize for the slightly busyness of the paper, really is worth understanding, because if you understand that in your ward, in your hospital, you will do better stewardship because you can make improvements. Are there environmental factors? For example, inadequate laboratory presence or provision? What are the goals? What are the social influences and the culture of your organization? What are the behaviors? Are there knowledge problems? Are there actually misconceptions that will lead to poor prescribing? Is there some professional identity and hierarchy amongst your organization? And what are the skills and the education requirements? And only when you actually can do some of this will your implementation improve, and you perhaps will get past that kind of 15% threshold that most healthcare systems and stewardship programs appear to function at. And how would you then do this better implementation? Well, it is not the topic of this subject, but I think that we're beginning to see increasingly use of behavior science. Implementation science focuses on what are the optimal strategies to promote what is good evidence in real world setting. And combined with that is focusing measurement of outcomes which are associated with an improvement of care delivery. Because at all times, we want to ensure that we translate the good things that research is telling us, but to make them relevant and valuable to the patients that we looked after. Because there's no point in having great research and great innovation if it's not being implemented effectively to ensure the better outcomes. And that will clearly not only improve outcomes for the patient, but the overall quality of healthcare. And using behavior science is increasingly interesting in terms of ensuring the fidelity of what we do in everyday life, using the COM model of is there capability, opportunity, and appropriate motivation in your setting that will then lead to the appropriate positive behavior change. And in our case, that is all about ensuring the antibiotic being prescribed. Indeed, the infection control and the stewardship community across the world is now talking about how we introduce the simple basic science of improvement and implementation into everyday clear practice, so that we can actually make the jump from where we currently are, around the kind of 15% improvement across the different sectors of healthcare interventions. But is there something else that we can potentially do that will make us improve? Well, my role is to talk about the role of improving better use of existing diagnosis as well as new diagnostics. And Jim O'Neill said in 2015 that diagnostics are the single biggest potential game changers. But I'm sorry to say that every year I go to a meeting, I'm still hearing about that. And we really need to move to the next step of using existing and new diagnostics into everyday real world practice. And every healthcare strategy from the UK, as is this one, or the US, suggests that we ought to be doing that because they are available in the everyday clinical practice. But we must address existing poor practice without the need for rapid diagnostics. And this study from the US shows that not only do we not de-escalate adequately because we don't take cultures, and good quality taking cultures in everyday practice can be addressed, and you don't need anything fancy to be able to do that. We also don't do basic microbiology specimens enough very well. They're often of poor quality. They are not from the appropriate site. They are not what the clinician is looking for in a timely fashion. And when they are not appropriate quality, you can't do susceptibility testing and so on. So there are a whole bunch of process things that require sorting out before we actually think about the role of new diagnostics. And at all times, there should be an integration between the laboratory and the diagnostics with infection prevention and control practice, as well as antimicrobial stewardship. And only when you have those three working in harmony together will we achieve many of the things that we want to do to get past the kind of 15% improvement that we seem to be stuck at. Simple things we currently have is that we take up to 72 hours to get a positive culture back. And that increases the medical period of uncertainty, often leads to inappropriate prescribing and physician anxiety. And when we reviewed the range of interventions to support better decision-making and better stewardship in a systematic review, rapid diagnostics and biomarkers, as you'll hear about shortly, were only beginning to emerge into systematic reviews of how we can improve the effectiveness across a range of outcomes of antimicrobial stewardship programs. And this survey from the ISAC across the world really talked about how rapid diagnostics will impact not only on stewardship, will impact on improved mortality, better compliance with specialist advice, more more de-escalation, as well as outcome markers such as length of stay and less use of isolation facility, which in current climate is very, very topical. There are a range of rapid diagnostic tests that are emerging, but the challenge remains of getting them adopted in a systematic fashion into everyday clinical practice. So we know, for example, that we can actually bring about a reduction in broad spectrum use by using rapid multiplex PCR, but with a robust, highly active stewardship team that will then ensure that the great rapid diagnostics is offering is then integrated into clinical practice. There's no point in having great rapid diagnostic tests if they're not aligned to a good stewardship team that will then ensure that they are used appropriately, effectively, with the result of good outcomes. And this slide shows the value of a bunch of rapid diagnostic tests, in this case for looking at gram-negative infections, on very important outcomes, not only in terms of de-escalation, reduction in broad spectrum treatment, and often reduction in combination treatment, because you have a rapid diagnostic test is giving the clinicians important information and that stability to be able to then make those appropriate decision-making processes. So I think that rapid diagnostic tests are very, very important. They need to expand, and we need to think about how we can justify some of their costs. But I think if you look, for example, I'm sorry to run through these last few slides a little bit more quickly, in terms of are they cost effective? And this very eloquent analysis for a range of rapid diagnostic tests shows that for many of the tests, a rapid diagnostic test, be it a MALDI-TOF or a PCR or PNA-FISH, whatever it is, if combined with a good stewardship program or a good stewardship team, are within the range of cost-effective interventions for a range of things that are now recognized as appropriate in a healthcare setting. So when it comes to which rapid diagnostic test to use, you need to ensure, is this the right test? Is it the test for the patient is appropriate for that test, and is it the right time? So at all times, the antimicrobial stewardship component needs to be integrated into the decision-making process that the diagnostic stewardship will act. And if the two are done together, you will then optimize the effectiveness of the rapid diagnostic tests. The biomarkers and their value in everyday clinical practice will be soon addressed by my colleague, Professor Philipp Schuetz, and I look forward to hearing from him. But how would I like to conclude with 3 things to tell you about and a unifying message? I think we need to understand what are the barriers and facilitators to effective implementation of stewardship programs. And by doing that, you will get better implementation. But if you're going to implement more effectively, you need to understand the context, you need to understand what works where, why, when, and what is sustainable, and you need to think about the range of interventions that you have available to make that happen in your healthcare facility. When you look at the role of diagnostics, particularly rapid diagnostics, I believe firmly that they have a very important place. But you need to understand, where are you using them? Why are you using them? What's the infrastructure and support that you have around them? What are the current systems in place? And what are new things you may want to put into place so that that particular diagnostic intervention is clinically as well as cost effective in a real world setting. And I think that is an extremely exciting time to introduce these interventions into our everyday clinical practice. So my summary message is that whilst innovation is wonderful, it brings us some really strikingly important tests, but diagnostics needs to be integrated into better implementation, which means what, when, how, why, and for how long. And if we do that, we will not only achieve better outcomes from our stewardship programs, we will achieve sustainable outcomes from our stewardship programs. Thank you very much for your attention, and I look forward to your questions. Thank you.
Thank you, Professor Nathwani, for your presentation. And the who, what, where, when integration of antimicrobial stewardship with diagnostics are some of the questions coming in. Some of those being developed countries versus lower to middle income countries and how that may vary. So be thinking of a response to that, Professor Nathwani, for the Q&A session. And before I introduce Professor Schuetz, I just want to remind all of those listening, you can engage with our speakers through the question or chat box. So please send us your questions as they arise during the presentation. So for part two, Professor Philipp Schuetz, role of PCT or procalcitonin in stewardship relative to other biomarkers. For those of you that don't know, Professor Schuetz is very much an expert on this topic. It's been the focus of his research and his publications for many years. He's an assistant professor, endocrinology, diabetes, clinical nutrition, and internal medicine at the University of Basel in Switzerland. And I'd just like to welcome Philip and take it away with your presentation. I just need you to come off mute, Professor Schuetz.
Thank you very much for your kind introduction, and welcome everyone. This was a great talk by my colleague, and I think he pointed out a lot of different strategies for the antimicrobial stewardship. Now, I would like to focus on one particular part, which is the biomarker part. And of course, the biomarker part just looks at one specific topic, which is mostly the host response to the infection. And I think it's very important to keep in mind that for a efficient stewardship, we need to look at all different parts together. But I like to just focus now on the biomarkers, particularly procalcitonin, because I have dedicated quite some research to that. And I think it helps to understand how biomarkers may support us in the decision-making regarding antibiotic stewardship in a single patient. Now, when we talk about a patient with an infection, a patient with sepsis, of course, there are different measures and steps we have to take. So first of all, it's recognition of sepsis, which is challenging. It is the initial resuscitation and the decision whether we want to treat a patient with antibiotics, with fluids, because we believe it's a septic event. Then it's diagnostic management. Does he need surgery? Do we need to go into to treat the infection particularly? And of course, then it's the supportive management. And so I would like to talk how a biomarker such as procalcitonin can support us in these different important steps when managing a patient with infection or with sepsis. So particularly, I would like to talk about three questions. So the first one is, do we really get prognostic information from the biomarker, from procalcitonin? Does it help us to understand whether a patient is responding or not, whether a patient is at high risk, or does it help us in the risk stratification? So the second question then is, does it help us in the decision-making regarding antibiotics? And so I think here we need to really look at two different clinical situations. So one situation would be a low-risk patient where, based on the clinical grounds, based on culture results, we do not believe that the patient really has bacterial infection, but we would like to have another piece of information for rule out. So the biomarker would help us to rule out that the patient has bacterial infection, which would potentially lead to not using antibiotics in such a patient. And then there's the other situation where we do believe that the patient may have an infection, or we are sure he has an infection, and we need the biomarker to monitor the patient to understand whether the patient is responding, to understand whether we can de-escalate or stop antibiotics, or whether we need to change our strategy if we believe a patient is not responding. And then, of course, the third and maybe most important question is, if we use the biomarker approach, do we really have any impact on the clinical outcome of the patient? Can we improve the outcome of sepsis? Can we improve mortality? Because in the end, we only want to measure a biomarker if we believe that a patient shows benefit in the end. So I'd like to introduce just 2 cases to you, just to show you 2 typical cases and how we can use the biomarker for these cases differently. So one case would be, you see a 66-year-old male patient, he's a smoker, he comes in maybe the GP office because he has a history of cough, he feels feverish. We do maybe a chest x-ray, we don't see an infiltrate. So we don't believe that this patient really has severe pneumonia. However, I would argue that this is one of the most typical situations where the patient would still walk out of the GP's office with a prescription for antibiotics, just in case, because we are not 100% sure this patient doesn't have bacterial infection. So just in case, he may get antibiotics. So this would be a typical case where we would like to rule out that the patient has bacterial infection. Now, the second case would be a 55-year-old female patient who comes into the ER and later the ICU because she does have pneumonia, severe pneumonia. So you can see she's in septic shock, she has low blood pressure, and it's very clear this patient needs antibiotics, she needs the best sepsis care we have. But for this patient also it is important to do a great monitoring, because maybe after a week, maybe after 5 days or 10 days, she does not need antibiotics anymore. So we need to have a marker telling us whether we are on track, whether the treatment is working, whether we can de-escalate, or whether the patient needs another strategy. So let's go back to our 3 main questions. So do the biomarkers really give us prognostic information? And so I think to answer the question, it's important to understand the kinetic profile of these different biomarkers. So here you can see in blue, this is the procalcitonin kinetic as we see it after endotoxin challenge. And you see it takes about 6 to 12 hours for PCT to increase. And after about 12 to 24 hours, we see normally that it hits the high and then shows a decline of about 50% every day. So this is the typical PCT kinetic. Now we have learned from studies that particularly the drop in PCT levels gives us most of the prognostic information. And if PCT does not drop within this expected time range, this usually points us at a risk for adverse outcome of the patient. So if we do not see that the PCT level is dropping once we start our sepsis management, we have to suspect that something in our treatment strategy is not working. Now you see also some other biomarkers here, C-reactive protein, which we use a lot in Europe, which is more an inflammation marker. We use it now with the COVID patients a lot as well. You see it has a bit of slower kinetic and it's less specific towards infection. It's more an inflammation marker. You also see IL-6 or TNF-alpha, which are very rapidly increasing. However, these markers seem to have a higher variability. And so as a stewardship marker, it has shown to be a bit less reliable because it has more variability and though changes much faster. So there is many studies that have looked at PCT and looked at how the kinetics may help us to understand the risk of a patient. And so this is one of these studies from about more than, I think, 10 years ago from Geneva. And so the colleagues there, they compared sepsis survivors to non-survivors. And so when just looking at the graphs, you can see that in survivors and non-survivors, you have patients with very much elevated PCT levels. But I think the initial elevation of PCT is not even the point here. The point is more what happens over time. And so you can see in the survivors that the trend towards a decrease in PCT is much stronger compared to the non-survivors. So the prognostic information does not come really from the initial level. The initial level will tell us the patient is really sick and he has a high risk for sepsis, but it does not tell us whether the patient really is responding to treatment. And I think this is most important regarding his prognosis. So about 5 years ago, we completed a large US-based study, the MOST study. And so this was an FDA study which had the purpose to prove that the kinetics in PCT over 72 hours provides prognostic information beyond that we have already from other clinical scores such as SOFA score. So it was very clear in the study that if a patient didn't have a decline in his PCT level more than 80% over 72 hours, then his risk for mortality was twofold increased. So PCT decrease over time, I think, is a very strong prognostic indicator. And if we see a decrease of 80% or more over 72 hours, this tells us that the patient is responding to treatment, and it gives us information about the prognosis regarding complication risk and also regarding mortality. So with this prognostic information now, and also knowing that PCT increases in response to bacterial infections, can we use it now as a biomarker in our antibiotic stewardship program? And so there is also a lot of different trials that have asked this question. Can we integrate PCT in our clinical decision making? Do we see a result, a difference in antibiotic prescribing patterns? Do we see lower exposure to antibiotics? Is this strategy in the end safe, or do we see more problems when we use less antibiotics based on the biomarkers? And so these different trials all had a similar trial design, and you can see these were all randomized trials where patients were randomized either to a standard of care group where antibiotic prescribing was based on the usual hospital routine, or to a biomarker group, the PCT group, where the prescribing was based on clinical judgment in addition to to the PCT result. And of course, in the trials, physicians were received the result of the PCT test, but also a recommendation with that regarding how they should interpret the result and what should be their consequence regarding antibiotics. And so it was a pretty easy design, as you can see. So there were like 4 cutoffs, and the lower the PCT level was, the lower the risk that the patient really has a bacterial infection or that the infection still needed antibiotics. And so there was a recommendation against antibiotics if PCT was smaller than 0.1 or 0.25. But if it was higher, then there was a recommendation for the use of antibiotics and to keep on monitoring the PCT result over time. And so let's say a patient came in with a PCT of 1. We would recommend to use antibiotics, and after 3 or 5 days he was at 0.1. Then the recommendation was that this patient had no more evidence from the biomarker that antibiotics were necessary, and so the recommendation was to stop antibiotics after 5 days. And so you can, of course, appreciate that this allows us an individualized approach. So while in the standard group, physicians often tend to give fixed doses of antibiotics. So pneumonia, we give 7 days or 10 days or 5 days. The biomarker approach allows us to give the antibiotics based on the host response. And so maybe for one patient, this would mean 14 days, and for another patient, it will only mean 3 days. So the question, of course, is this really helping us then in decreasing antibiotics, and what happens to the clinical outcomes? So we then also did a meta-analysis based on all these different trials, and because most trials were done for patients with respiratory tract infections, we focused this Cochrane meta-analysis on patients with acute respiratory infections, and we were able to get individual patient data from all these different trials. So we were able to pool these data and to really look into the different types of diagnoses very specifically. So what's the effect for pneumonia? What's the effect for COPD exacerbation? What's the effect for bronchitis and other types? And so this is a summary slide from this publication. And so you can see on the right side that overall, we had about a 2.5-day reduction in the use of antibiotics in patients managed by a PCT algorithm compared to the control group, so 8.1 versus 5.7 days. Now, importantly, this effect was very different based on the type of infection. So you can see you have like two effects. So one of them is that on day 0, you have a lower initiation rate. And this is particularly true for COPD patients, for bronchitis patients, for milder types of infections. But then on the other hand, you also have early stop of antibiotics. And this was true more for patients with pneumonia or patients with sepsis. So again, coming back to our patient, so this first patient coming to the GP, he doesn't have any evidence for bacterial infection, but maybe the patient is used to his antibiotics. Also, the physician may be used to give him his antibiotics because it always works. And so if this patient has a low PCT level, the physician would then not treat this patient with antibiotics because PCT would help him to rule out that this patient needs antibiotics. And so you can see here, this is the group of patients that was managed in primary care. And so this is exactly what you see. The dark lines here are the control group, and you can see the light gray is the intervention. And so we have a reduction in the initiation of antibiotics for GP patients from about 60% to about 20%. So this is a very strong effect. And this is just by encouraging the physician and the patient that really, in this case, antibiotics is not necessary. And you can see that overall, this results in a very strong reduction of antibiotic consumption of about 80%. So again, for our second patient, the patient with the monitoring, so the ICU patient with sepsis with pneumonia. So for this patient, the results look quite differently. And you see here, this is a subgroup of ICU patients. And you can see on day 0, there was no difference. All these patients coming in with sepsis, they were receiving antibiotics. So PCT didn't change the initial management, but you can see after 4, 6, 8 days, we have a higher number of patients where antibiotics were stopped early. And so overall, this again led to a reduction of about 14 to about 10 days of antibiotics, so about a 30% reduction in the duration and the exposure of antibiotics. So it seems that this strategy can work to reduce antibiotics, but of course, we do not want to reduce antibiotics in the wrong patient. And of course, we want to keep our patients safe, particularly if they're very sick with sepsis, or we do not want to not treat a patient coming in the GP practice, but then later having a severe bacterial infection and needing emergency care. So I think looking at clinical outcomes is very important in this context. And so here we have, with the meta-analysis, we have a very strong tool to look at clinical outcomes because we have a lot of data. So currently we have about 10,000 patients from all these individual trials in the meta-analysis. And so we do understand the safety profile of PCT in the different types of infections. Now, interestingly, in 2016, there was one very large study, the SAP study, which was done in the Netherlands. And the Netherlands, they do have a very strict antibiotic policy. So control group patients in this trial already had a very short antibiotic treatment duration. And it was again reduced by the use of PCT by about 1.5 days. But what was more interesting in this trial was not so much the reduction of antibiotics, but really the clinical outcomes. And so here you see the survival curves, and you see that there was a significant reduction in the risk to die within a year of the sepsis event in patients managed by PCT levels. And so this is the same we also found for the overall cohort. So you see here 30-day mortality and also treatment failure, which was not significant for this analysis, but points towards a lower risk of treatment failure and a significant reduction in mortality. And so it's always difficult to understand what are results from a meta-analysis worth. So my conservative interpretation here would be that we do not, for sure, not see any worse clinical outcomes if a patient is treated with PCT and if his antibiotic treatment is guided by the use of this biomarker. And of course, you can ask, well, why should the biomarker now reduce your mortality risk and your complications risk? And I think Dilip in his talk already gave us a great answer. And we do know it from different stewardship studies that if we use less antibiotics, if we are more specific, if we understand if the patient really has an infection, if the infection is controlled, if we use antibiotics more individually, we do see in a lot of different trials that these patients have a lower mortality. And so for PCT, there's several arguments that are being discussed. And you can see, first of all, low procalcitonin might prompt clinicians to seek alternative causes of symptoms, so maybe heart failure, lung embolism, something like this. Also, the kinetics of PCT and the lack of reduction of PCT might identify early non-responders and help us to change our treatments. And also, of course, we have less antibiotics, less side effects, which could also be an important factor for these patients, why they do better if we use the biomarker strategy. So why is then PCT not used more widely? And it is, I think it is used more widely here in Switzerland. It is also used in some hospitals, some regions in the US, but there is also regions and hospitals and physicians, not only to show the nice trial results, but also talk about the potential limitations. So first of all, PCT is not an easy to use biomarker, but it's a biomarker that needs education. You need to understand that a patient with an infection with sepsis, it's a highly complicated situation, and you cannot just reduce it to one PCT measurement and now you understand the patient. The PCT result needs also to be, the interpretation needs to be based on the clinical setting. So are we talking about an ICU patient where we have higher cutoffs to stop antibiotics, or a GP or emergency department patient? Also, there is false positive, false negative. So if a patient comes in with cardiac arrest and he has a high PCT, it doesn't mean this patient has sepsis. All different types of cytokine storm can lead to an increase in PCT levels. On the other hand, we do have types of infections, such as localized infections, where we not see a very strong PCT result. I also believe that an initial only one measurement of PCT gives us just not enough information really for management of a patient. This may be good in a GP situation, but in a hospital, I really believe that the kinetics is very important. And then, of course, PCT is just one piece in the big puzzle of this patient. So we also need to look at the blood culture result. We need to understand what type of infection does the patient have. So we cannot make it too easy and just only look at the biomarker. Also, it's important to understand that we need to have a high sensitive PCT assay. So there has been other types of semi-quantitative assays, which are point of care and which give us very rapid results, but these results may not be as accurate as it should be for an important decision regarding antibiotics. And of course, not all research has been positive. And I think the most prominent one is the large US-based study from David Huang from Pittsburgh and from the PRO-ACT investigators. And so really in this very large trial, the investigators did not find that the PCT led to a strong behavioral change in the doctors. And so personally, I believe one problem here was that a lot of the doctors were just not used to the biomarker strategy. So they were participating in the trial. They did not have a lot of exposure before. And of course, they had some sort of education, but adoption of such a biomarker strategy really needs time, needs experience. And after time, we see behavioral change. So I believe it's a biomarker that really needs education, that needs time, until you see that physicians change their behavior regarding antibiotics, and Dilip has also given us some examples before. Then, of course, there is cost, the cost issue, and I think this is important, and there has been some cost analyses. These analyses are very clear. So if you measure PCT and it leads to a behavioral change and a reduction in antibiotics, you will save money. This is going to be cost effective. If you measure PCT but you don't change your antibiotic strategies and you do the same as you did before, then you're just wasting your money. So basically, when you use PCT, I think it's important to have a stewardship team and an educational team in place that really helps you to make physicians and users understand how this biomarker is intended to be used in hospital. And of course, there's different types of infections. I've been talking now about respiratory infection. We do have great data on sepsis, also on meningitis, but there's other types of infections, endocarditis, abdominal infection. And so here we clearly need more studies to really understand how to best integrate the biomarker into the overall strategy. Now, of course, we have a new player, the situation with COVID. And so here we do not really have too much data. But I have seen that in most of the COVID patients, we see a low PCT level when patients come in. I think it also gives us prognostic information. And in some patients, we see after a couple of days that PCT increases. And so I think this is a situation where we have to be very careful for the patient. It may point to secondary bacterial infection, but it may also just tell us that this patient is deteriorating. So here is again an example how we should use PCT, and you can see I think we should use it based on the clinical evaluation. What's the certainty of our bacterial infection? We should then use PCT and look at the probability. If it's low, it gives us a low probability. And together with our clinical assessment, with our microbiology, we can then make further decisions regarding antibiotics. And so this is also a bit different whether we are in ICU, where every patient with a sepsis diagnosis should receive antibiotics, or if we are in a lower risk setting where we can where we have more time to consider the initial treatment. So to sum up, I think PCT gives us information initially on the risk that the patient has, bacterial sepsis. It helps us to monitor the patient and tells us whether our treatment is effective, and finally whether we can discontinue antibiotics. And I think by doing this, we can really reduce antibiotics in a meaningful way. And we have good data that suggests that we are actually improving patient outcomes. So with that, I'd like to conclude. I think PCT is an interesting approach. It helps us in the antibiotic stewardship. It is just one piece in the puzzle. And of course, we have to take it together with all the other efforts that Dilip has nicely summarized in his first talk. With this, I'd like to stop here and thank you all for your attention, and be happy to answer any questions you may have. Thank you very much.
Thank you, Philipp, for that presentation and background in the utility of PCT and its ability to help reduce antibiotic use and appropriate use. The final slide here is for our attendees, and then I want everyone to realize that we've got now time for question and answers for our speakers, which is always the most fun part of the entire webinar. But to receive your continuing education, you will go to the ProCE website there, www.proce.com. Do this by December 4th, and the attendance code I will read out loud for anyone that's just listening to audio. It's CNT46F, as in Frank, and you will need that code to receive your CE. All right, we're ready to head into the Q&A session. We have both Dilip and Philipp live here. And Dilip, I wanted to start with you. I think you've had a chance to look at a few of the questions that have come in pertaining to your presentation. And not sure if you have a particular one you want to answer, but I thought related to your presentation, you talked about barriers, and you also talked about implementation and how there's been a 15% improvement to prescribing and antibiotic use when appropriately implemented, but can we do better? I assume that the barriers are different depending on the setting, about country versus a lower to middle income country, and that your potential for impact could be greater than 15% in some of those settings as well. So we've got some questions related to that, important steps that they can take, how that barrier might be different in a lower to middle income country. I know you've got that experience. And what are the key diagnostics they should focus on in the lower to middle income countries?
Okay, so thank you, Marnie. All very good questions. And the reason for deliberating on the implementation bit is that I think that we often will just rely too quickly on what's the next great test that's going to get me where I need to be. But actually, if we actually implement processes of care more effectively, we will make a significant inroads into doing better, while not always relying on the new tests, which are very important, as I said. And I think that the only way of doing that, and I talk to many people starting stewardship programs, doing stewardship programs in the early stages, mid stages, and late stages. What many do not do is take the time to understand where the barriers are in the system that they're looking after. And I think that really understanding those, are the technical barriers, are the behavioral barriers, are the structural barriers, will be able to make those processes much better. And it's working with those stewardship teams. And the other thing that people will also do is that they'll try to make too many changes and do too much, and you confuse everybody. So I think that one of the questions here I've got here on the online is somebody from Pakistan talking about where would they start when they have nothing. I would just start with one area, which is high burden, high impact, but you can do it with low number of resources. And all you require then in those cases is getting a champion, getting some very simple processes that you will place into place, getting leadership commitment, implementing them, measuring them, and changing them. So the short answer is, I think you need to be much more focused. I think we try to do too much, and we need to work in small steps. And that's easy to say. The one thing human beings do is they try to do too much, and they will not have the capacity to continue to have a sustainable success.
Thank you. Philip, a question for you pertains to how you integrate the information of PCT, the biomarker, with the diagnostic test that might be for the microbe. And so I have that question, bacterial versus viral, and then maybe you can expand on your experience if you've had any with COVID patients.
Yes, this is a great question, and I think it's the everyday challenge we face. So optimally, we have a patient where clinically we have a low risk situation for bacterial infection. We do a test which shows us that this is to the same direction. Then we should not use antibiotics, of course. So sometimes it is not, sometimes it doesn't match up. So sometimes we do see that PCT level is low, but we do not find the virus, or PCT is high, we do find the virus. Of course, we also have strong limitations regarding the diagnostics, because we all know that a lot of patients with viral pneumonia, they can have superinfection with a bacterial infection on top of that. And so the same is true for our COVID patients. So typically what I've seen is low PCT levels, but high inflammation. So CRP levels, white count is up, PCT is low. This is the typical COVID situation. And in some of these patients, during treatment, we see that they get worse. They need maybe more oxygen. maybe they have a worsening of infiltrates. And sometimes we also see that PCT then increases. And I think this is a situation, where we have to suspect that this patient could have, on top a bacterial infection. And so we typically, would use antibiotics in such a case, because then the risk just goes up so much. There is not so much literature in my knowledge that has really looked at this, in more detail. And one of the problems being that for a large proportion of these patients, we just do not know what's going on, because we have negative cultures, but we believe it's a bacterial infection. We're not sure about the viral strains. So often it's really a very difficult situation, and we have to look at clinical examination, biomarker as a marker of host response, and the information we get from the micro lab. And I think together you have to make the best individual decision for your patient.
Thank you. Thank you for that information. It's very valuable, and you're treating and consulting on patients on a daily basis. So it's very real-time information for the audience. I have a question for both of you, which is, what would you feel, I guess backing up, you talked about the importance of implementation, of integrating the stewardship practices with the diagnostic stewardship. What do you feel is the #1 barrier to that integration? And I'll start with you, Dilip.
Okay, so that's a really, really good question. I think that when somebody implements an antimicrobial stewardship program, the diagnostic bit is done often as an afterthought. And I think that there needs to be a robust engagement between the laboratory staff, the clinical staff, and that's including the attending clinical staff as well as ID micro, about what do you want to achieve and how will the lab play the role, and what is the kind of capacity and capability of the lab to be able to give you what you need to do, and how are you going to engage and communicate? Because you can have the best lab giving wonderful results to the clinical community, but the clinical community is not engaged with them and not use them effectively, and like communication, there's a barrier, you will fail. So I think it's really important to get all the 3 bits together: the lab engaging with the clinical community and the stewardship community, and for that argument, the infection control community, in a kind of collegiate way. And each must understand the limitations of what they can offer in a particular clinical setting. And not enough people spend time in doing that. And what you get is, I really don't find the lab very helpful, and I will continue to prescribe whatever I prescribe. I think we must make sure that they're at the onset of the stewardship as opposed to the middle or an afterthought.
Yeah, I think this is a great point, and so I see in my practice that the diagnostic uncertainty, which you will never get rid of 100%. I think this is something we really need to learn to deal with. So if we have a patient and he has a cough, he has fever, but he has negative cultures, he has a low PCT or biomarker result, and nothing is pointing towards bacterial infection, or he has been treated for a week and he looks much better. Of course, we do never know 100%, if this patient really can go without antibiotics. But all the different tests, we have the clinical examination, our lab tests, PCT, our results test, all of them just have some limitations. And I think as a treating physician, you just need to, you need to look at the big picture. You need to talk to your patient, and sometimes you also need to make a decision, and go for the overall picture. And I think if we do a too defensive medicine and just want to be 100% sure, and just in case, do all these treatments, I think in the end we're hurting the patient more than we're actually helping him. And I think this is important to understand.
Thank you, Philip. We're at the end of our time here, so we need to close it out, unfortunately. Final, if you could answer in maybe one sentence, Dilip, the one thing today that practitioners could do to affect antimicrobial stewardship, and I guess that would be behavioral, through education, diagnostics, what would be the one thing that you'd have them focus on today?
I think more effective implementation, and if I'm allowed the second bit, is integrating new technology into everyday practice.
Thank you. Philip?
Well, I think it's important to focus on one thing and really do it right. Do it with education and do it with dedication. And I think this is the most important. Really understand what you're doing and take the time for education and for doing it in everyday practice, and not just talk about it, but really doing it with passion. I think this is most crucial.
Yeah. Education is so valuable and at the foundation of all the other implementation strategies and overcoming barriers. I want to thank Professor Nathwani, Professor Schuetz, taking time out of your busy day this afternoon to speak with all of us, for our registration participants as well, and also for the CIDRAP team, as well as bioMérieux, our educational grant sponsor, for supporting us. And with that, I need to close. And this was a recording, so you'll be able to re-review it at a later time, and that will be available on our website at cidrap.umn.edu/ASP. That recording will be available, as well as information about retrieving your CE. So thank you all, and the slides will be available at a later time as well. Thank you very much.
Bye.
Have a safe and good
Very
evening.
much. Bye-bye.
Thank you.